we would like to invite the next speaker, Professor Jaspreet SUKHIJA, to talk about high concentration atropine in myopia.
Thank you. And moving on to higher concentrations, 0.01%, which is the most widely studied and has been there for some time. But there are other concentrations which have come up. And why is there a shift in the practice to higher concentrations? There are globally 30 registered trials which are going on from low concentrations to high concentration. And we're going to have the results very soon. And low dose atropine is shown to reduce the refractive progression, but not a significant impact on the axial progression. This is shown by these studies. The problem with why do you want to reduce axial progression is the myopic maculopathy. If you see, the odds are like 2 times at -3 and they increase to up to 120 times at -7 diopters. So that's very important. And higher concentration has been shown to retard axial elongation. Who are the patients who are at risk? It's the younger children. They require higher concentration for a treatment effect. So if you initiate 0.01% in a young child, this could lead to a delay in implementing an effective dose, and progression is the most rapid during this stage. Also, the associated factors for poor response to low dose atropine are still not clear. So these are the higher concentrations which have been used, ranging from 0.025 to 0.1, 0.5 and 1%, which was early used for uveitis, that's commercially available there. So the first study which was done was on 1% atropine. So what they found had the best efficacy in slowing myopia. The problem was the high dropout rate because of the side effects of photophobia. Then they tried with lower concentrations in 1999, Shia et al. With 0.5, 0.25 and 0.1. So they had decreasing concentration. What they found was that the mean myopia progression was again dose dependent, with 0.5% showing a good response. But the problem was that the side effects were almost close to 22% in 0.5% group, and there was no placebo group and no axial length data was available for these studies. So as was being just mentioned in the previous talk, the ATOM-1 study, where they used atropine 1% versus no drops and placebo versus no drops, what they found in their study was that the myopia progression was much more where they did not use atropine. The axial elongation was again more in the group where they did not use atropine, but the rebound was much more where they used atropine. And the side effects were almost close to 18%, while they were nil in the ones where they did not use atropine. So the side effects are a problem here, the rebound was a problem here. Then in the ATOM-2 study, with the duration of 2 years, they used 3 concentrations, 0.1, 0.5, 0.1 and 0.01%, and again the myopia progression was dose dependent, if you see. Much less with the higher concentration and much more with the lowest concentration. The axial elongation was similar in the 0.5 and 0.1% group. And what they concluded was that the effect of 0.01% atropine was based on decrease in the mean refractive error rather than the axial elongation. A similar rebound was seen between these two groups. And so we have Jason Lamb here, basically, who's done a wonderful study, and obviously probably one of the longest studies for 5 years using 3 concentrations, 0.05, 0.025 and 0.01. Initially the methodology was 2 years of treatment followed by a 3rd year washout in one group and continued treatment in the other, and analyze after 5 years of treatment. So among the 107 children, about 79.4% needed to restart the treatment in the PRN treatment group. But those who needed to restart the treatment was almost similar in the 3 concentration groups. You can see almost similar, 82, 81, 85. And retreatment was associated with a younger age group with no effect of atropine concentration, sex or baseline spherical equivalent. So it shows the age which was having a significant effect. It was a dose dependent effect with a higher concentration, that's 0.05%, having a much better effect as compared to lower concentration. It was effective. They good tolerance over 5 years, and what they concluded was it should be continued for 5 years. The accommodative amplitudes and the photopic mesopupil size was same across all the groups. Now probably they're having an ongoing trial probably to check what really happens once you stop it. So that's going to be a big question, and we can have comments from Jason after this talk, really what's going on. So between the two groups, between the lower and the higher concentration, the spherical equivalent progression was they stopped almost by 67% in 0.05. The axial length progression was decreased by about 51%. The problem was photophobia here, almost 7.8%. So side effects are more if you use the higher concentration. And similar was the ATOM 2 extended study. Basically, if you see, these dark areas are the higher spherical equivalent, that is almost more than 2 diopters. So again, it was a 5-year study. They gave 0.01, 0.1 and 0.5 for 2 years. Then again, it was a washout period for 1 year. And then what they found was that greater rebound effects was noted with the higher concentration. So that is the effect, that is the, you can say, the higher refractive error coming in the 0.5% group. And year 4, when they restarted 0.01%, what they found was initially who had 0.01% had the lowest overall refractive progression. So that's the refractive progression here as compared to 0.5%. And they concluded that it's more clinically palatable, the lower concentration. So this is one of the recent studies by Lohmann. Obviously they gave placebo first, and finally after that they gave atropine 0.05% for 1 year. The decreased myopia progression, the axial elongation was not that significant compared with the placebo. The side effects were tolerable. Rebound again not yet studied. So the only issue was that atropine was given after 2 years of placebo. So the effect of age could also have a role in decreasing the myopia progression because it's been given after 2 years. We have Rohit sitting here who's done a wonderful study in India using high concentration atropine, that's 0.05%, for rapid progressive childhood myopia. There are 40 children who are fast progressors, and he found a significant reduction in the myopic progression rate of close to minus 0.5 diopters, which was significant with 0.05% atropine, and similarly was the effect in axial length progression. Of course, there was no correlation between the axial length and the spherical equivalent progression. Here what he concluded was response to treatment was independent of the age at baseline as compared to the LAMP study, a baseline refractive error, a baseline rate of progression, gender, and a family history of myopia, and there were no side effects reported with the higher concentration of atropine. In one of these meta-analyses, probably one of the largest meta-analyses being that was published in JAMA, what they concluded was that the adverse effects were less frequent with lower doses of atropine, and higher doses were not more effective. So basically, they advocated that 0.01% would be a better option in children with progressive myopia. So what is the concentration? We have discussed so many concentration. Is there any ideal concentration? Well, we are still coming out with 0.05%, the higher concentrations which is very effective in slowing myopia progression. But of course, until we have more studies, because 0.01% has been the one which has been studied for decades now, and it is commercially available, probably is for the timing is 0.01% until we have more data for 0.05%. So I like to conclude here by saying that the efficacy of atropine is dose dependent. 0.05% is proving to be a well tolerated concentration. No study on rebound after stopping as yet. The maximum effect of higher concentration, which was seen after 2 years of 2 years, showing myopia plateauing after 2 years. So basically, when they used higher concentration, the ATOM 2 study, they found that there was plateauing after 2 years, so you could shift to a lower concentration after that. So further studies could help explore the role for high dose atropine, especially for rapid progressors. What is our goal? Our goal is basically to slow the myopia progression during the years of most active eye growth. So it could be the initial choice in young children when you know that they are the ones who are going to basically progress fast, where you could have a much more axial length progression. Thank you so much.